Now let's start with the second part of this lecture, the middle ear. The middle ear is an air-filled cavity which is present in the petrous part of the temporal bone and is sandwiched between the tympanic membrane laterally and the internal ear which is present medially. It is mucous membrane lined space. Now, for our understanding, we have divided it into three parts. The part which is which is medial to the tympanic membrane, corresponding to the tympanic membrane, this part is known as the tympanic cavity proper. But as you can make out from this figure, there is a part of this middle ear cavity which is present cranial to the tympanic membrane and a part which is present caudal to the tympanic membrane. The part which is present cranially is known as the epitympanic recess, and the part which is present caudally is known as the hypotympanic. For understanding, we likened this middle ear to a six-sided cube. However, the cube is pinched in the middle. So if you imagine a matchbox, and if you're holding the matchbox from its larger surface, the large rectangular portions of the matchbox, and you pinch it in between your fingers, this type of a figure you are going to get, this kind of a shape. So it is 15 millimeters in anterior-posterior diameter, 15 millimeters in vertical diameter, but it is pinched because the medial wall, that is the internal ear, is projecting into the middle ear cavity, as well as the tympanic membrane is convex towards the middle ear cavity. So because of that, there is pinching taking place in the middle. Its maximum transverse diameter is present in the area of its epitympanic recess, which is 6 millimeters. In between the two convex part, it is about only 2 millimeters in size, and below, near the floor, it is 4 millimeters in size. So it's a biconcave pinched disc, which is a pinched matchbox-like structure. It has a roof. For now, since we've imagined it to be a cube, to understand it better, we divide its walls to understand its walls and the relations of the structures which are present around it. So we divide it into its various, we call it to have a roof. It has a floor, a lateral wall which is formed by the tympanic membrane, and a medial wall which is formed by the structures of the internal ear which are impinging upon the tympanic membrane. A posterior wall which you can see behind, and an anterior wall which we've opened to enter into the middle ear cavity and to understand the structures which are present in it. Now, the contents of the middle ear are malleus, the three ossicles, that is the malleus, incus, and the stapes. The joints formed by these ossicles, that is the incudo-malleolar joint, which is a saddle variety of joint, the incudo-stapedial joint, which is a ball and socket variety of joint. Now, these ossicular membranes these ossicles increase the force of vibration of the sound wave which is coming in, but decrease its amplitude. Any pathology of these ossicles or these joints would result in decreased force, decreased mobility of these particular these bones, and decreased transmission as a result, resulting in conditions called the conductive deafness. Now, as you can see that these bones are attached to the walls by means of ligaments, and they have muscles which are coming onto it to bring about the movement. These muscles are the tensor tympani muscle, which arises from the walls of the auditory tube and get inserted into the handle of the malleus. So on its contraction, it's going to pull the handle of the malleus medially and thus decreasing the vibrations of the tympanic membrane. Similarly, this muscle is the stapedius, which arises from a projection which is present on the posterior wall of the middle ear cavity known as the promontory. From there, it gets inserted into the neck of the stapes. It is supplied by the branch from the facial nerve, and on contraction, again, the stapes is going to move away from the fenestra vestibuli, or the base of the oval window to which it is attached. Now, for these muscles, thus we have nerves, and also we know that we have the cauda tympani nerve, which is running through this cavity. So the contents include the ossicles, the joints, the muscles, the arteries and the nerves which are supplying the various structures, and the mucous membrane which is lining the wall. So I contend that the mucous membrane is lining its wall. And as you can see that this cavity is not a closed cavity, but it is communicating anteriorly with the auditory tube. So anteriorly, this is the middle ear cavity. So now which kind of a section is this? Can you imagine? We have a sagittal section through which we are looking at the middle ear cavity. This is the middle ear cavity. राइट हमने एक्सटर्नो अकॉस्टिक मीटर से हम अंदर चलते गए, हमने टिम्पैनिक मेम्ब्रेन हटाया, हमने सब स्ट्रक्चर्स हटा दिए, तो ये हमारी मिडिल ईयर कैविटी. This cavity communicates anteriorly with the auditory tube and posteriorly with the mastoid antrum cells. So although we liken it to a cube, but in this cube are present communications which are going anteriorly through the auditory tube or the pharyngotympanic tube or the eustachian tube, with which it communicates with the nasopharynx, and posteriorly it communicates with the mastoid antrum through an opening which is present in the posterior wall, which we shall see soon, the adductus to the mastoid antrum. So now let's study the relations of the middle ear cavity. We are entering the middle ear cavity from the lateral side, like the ENT surgeons. So laterally, the walls of the middle ear are formed by the tympanic membrane. A part of the tympanic membrane has been cut here to show us. This tympanic membrane, that is the pars tensa part of it, lies in the tympanic sulcus. You can see the margins of the tympanic sulcus also out here. So this is the tympanic membrane. Also present in the lateral wall are the malleus, or the epitympanic recess, which contains the head of the malleus, the incus, the body of the incus, as well as the short process of incus is present out here. Now, running in the lateral wall is the chorda tympani muscle, which is running medial to the handle of the malleus, as we've already discussed. And you can see out here that it is arising from the facial nerve, which is present in the posterior wall of the middle ear, and enters in the middle ear cavity through this posterior tympanic canaliculus, runs in the middle ear cavity medial to the tympanic membrane and the handle of the malleus, and exits the tympanic cavity or the middle ear cavity through the anterior tympanic canaliculus, which is a part of the petrotympanic fissure. Right? When you come to us, we will show you the petrotympanic, the petrosquamous fissures, and the structures which are going to be passing through it. The structures can be seen out here. This is the anterior tympanic artery, the chorda tympani nerve, and the anterior ligament of malleus are all entering or exiting through this particular part, which is the petrotympanic fissure. So on the lateral side, we have the tympanic membrane, we have the epitympanic recess, and in the epitympanic recess, we've discussed the contents which are present, and also in the lateral wall or in the lateral wall of the middle ear is the chorda tympani nerve. Now for the rest of the walls, let's make a diagram. Now this is a schematic diagram of the middle ear, which shows the relations of the middle ear to various structures which are surrounding it. Now some of these structures, because are impinging on the middle ear, they are forming some prominences. Some of them are showing some depressions. So we are going to be studying them and understand what are the relations of the middle ear. So let's first form the mastoid antrum. Sorry, the mastoid process. Anterior to the mastoid process is this. Since it's a schematic diagram, I'm making a cube which represents the middle ear. So this is the cube-shaped middle ear which we have to depict its various walls. This would be the roof. This is the posterior wall. The floor. Okay, the floor. Oops. And this would be the anterior wall. Right? So these are the walls of the middle ear. Anteriorly, we know it communicates with the auditory tube. So this would be the bony part of the auditory tube, which will continue into the cartilaginous part. So we are making an opening out here for the auditory tube. So we've got our communications and we've got the middle ear cavity the way we walked, right? So this is the mastoid, right? Here is the roof and this is the floor. Just to get your bearings. The lateral wall we've seen and we've removed the lateral wall and entered into the tube. Now the roof of the middle ear cavity is formed by a thin plate of bone which is known as the tegmen tympani. Tegmen tympani. This roofs not only the middle ear but also roofs the mastoid antrum which is present posteriorly. So this roof would be continuing all the way backwards. It separates the middle ear from the middle cranial fossa which is present out here. So over superior to the roof or the superior to the middle ear cavity, out here is the middle cranial fossa with the meninges of the middle ear in middle cranial fossa as well as the temporal lobe. Present in the roof are two canals which are running. One is present laterally and the other is present more medially. These are the hiatuses. These are the hiatus for, see, this is the plate of bone, which is the tegmen tympani. This is the petrous part of the temporal bone. So from the skull, we've taken this part. The petrous part of the temporal bone. This is the squamous part of the temporal bone. This part of the temporal bone is known as tegmen tympani. This is roofing the middle ear cavity. Again, to get your bearing, you can see this is the internal acoustic meatus, foramen ovale and foramen spinosum which is present. So यहाँ पर कहीं पर middle ear cavity पड़ी हुई है और उसको roof कर रहा है ये plate of bone which is known as tegmen tympani, and running in this plate are two hiatuses. The hiatus for greater petrosal nerve which is present more medially, and laterally placed hiatus for lesser petrosal nerve. So if this is this would be the hiatus for lesser petrosal and this would be the hiatus for greater petrosal. This hiatus will be continuing towards the foramen lacerum, while the hiatus for lesser petrosal would be in direction with the foramen ovale, and I'm sure you can tell me and you know why it is going towards the foramen ovale and what is its carrying. Okay. Now, what is the importance of the roof? Now, the importance of this plate of bone, and to understand it, is that when we have an infection in the middle ear cavity, there is a chance that this can breach this wall, this roof, and enter and cause meningitis or temporal lobe abscesses. Number one. Also, the veins of the middle ear are communicating with the sinuses which are present in the middle cranial fossa, and that would be the superior petrosal sinus which is going to be present out here, or it could be the petrosquamous sinuses. So when infections can also travel from the veins of the middle ear via this roof into via the veins which are piercing this roof and entering into the superior petrosal sinus. As a result, thrombophlebitis can be seen. The next structure which we are going to study is the anterior wall. So this is the anterior wall. Now first look at this picture. The anterior wall. So this would be the, ये हमने roof कर लिया, ठीक है? ये हमने roof कर लिया. अब हम यहाँ पर हैं. So anterior wall. So the anterior wall has a thin plate of bone which is separating the middle ear cavity from the internal carotid artery. The internal carotid artery enters into the carotid canal, which is now present somewhere here in the base, which we have seen somewhere here in the base. It comes in relation to the anterior wall of the middle ear cavity, and then it's going to come out here through the carotid canal and it's going to be exiting somewhere out here. So you can see this turn which it is taking the internal carotid artery. So let's draw. Here would be the internal carotid artery, and there is a thin plate of bone which is separating the internal carotid artery. Okay, so we've just taken a cut section, the internal carotid artery from the middle ear cavity. So this wall is also known as the carotid wall. And present, as you've already done, around the internal carotid artery is the sympathetic nerves. It is the postganglionic sympathetic fibers. These enter through this plate into the middle ear cavity. And these nerves which are entering are known as through the canaliculi. They are entering, and these nerves and the canaliculi are superior and inferior caroticotympanic nerves, which are these sympathetic fibers which are running from the internal carotid artery. Over that plate of bone is the opening for the auditory tube, right? The bony part, and thereafter it will continue into the cartilaginous part. The auditory tube, again, is forming a communication between the middle ear cavity and the nasopharynx, so that there is equalization of pressure on both the sides of the tympanic membrane, so that it can vibrate comfortably without any problems. But it also serves as a channel from which the infections of the nasopharynx and the nasal cavity can enter into the middle ear, right? Then over this is another opening, which is for the canal, and lies a canal of tensor tympani muscle. The tensor tympani muscle, we've already seen, was a content of the middle ear. It arises from the cartilaginous part of the auditory tube. It arises from the surrounding petrous part of the temporal bone, as well as it arises from the surrounding petrous part of the temporal bone, the auditory tube, right? It enters into the middle ear. Now, this plate of bone which is present between the two canals. So, this is the canal for tensor tympani muscle, and this is the canal for auditory tube. Now, this plate of bone which is present between the two canals, this is prolonged backwards onto the medial wall. And this forms a hook-like structure on the medial wall, which is known as processus cochleariformis. Now, around this hook, the tendon of the tensor tympani turns laterally. So, it is present in the anterior wall. It is turning laterally to go towards the handle of the malleus. On contraction, this muscle is going to pull the handle of the malleus more medially, and thus decreasing the force of amplitude, or decreasing the amplitude of vibrations of the tympanic membrane, which is essential to protect the internal ear. This is supplied by the mandibular nerve. The tensor tympani muscle is supplied by the mandibular nerve, which you already know. So this is important to remember out here, that this hook-like process which has gone on to the medial wall. And how is this hook-like process formed? This is formed by the extension of this plate of bone which is present between the canal for tensor tympani and the canal for auditory tube. I hope you're drawing this diagram with me, because it's very important to get your bearings in the middle ear cavity. All right. Then we come on to the floor. In the floor, or related to the floor, is the superior bulb of the internal jugular vein. So if you remember again, the internal jugular vein, this is the continuation of the sigmoid sinus, which would be running out here. Then there is this jugular foramen through which the internal jugular vein exits out, and here it forms the superior bulb of the internal jugular vein, which is related to the floor, which is also known as the jugular wall. Also present in the floor is a small opening through which enters the tympanic branch of the glossopharyngeal nerve. Glossopharyngeal nerve exits through the jugular foramen. It gives rise to a branch which is known as the tympanic branch, which enters into the middle ear. It is entering into the middle ear through the floor is the tympanic branch. I hope you can understand where I'm going. Tympanic branch of the glossopharyngeal nerve. All right. Then comes the, so we've done the roof, we've done the anterior wall, we've done the floor. So now let's do this wall, which is the medial wall. Now you have to remember, iske more medially kaun pada hai? Internal ear ke structures. So wo kya the? Cochlea, we have the vestibule, and we have the semicircular canal. Now some of these structures would be making an impression. The cochlea, you know, has turns around it, right? So the basal turn of cochlea forms a prominence on the wall of the middle ear, which we saw earlier also, because of which the middle ear cavity was appearing pinched. This is known as the promontory, which is formed by the basal turn of the cochlea. And on the promontory, the keratotympanic nerves, as well as the tympanic plexus of nerves, as well as this tympanic branch of the glossopharyngeal nerve, form a tympanic plexus. And a branch from this tympanic plexus is the lesser petrosal nerve, which runs in the roof. Right? This lesser petrosal nerve is carrying preganglionic parasympathetic fibers for the parotid gland to the otic ganglia in this from the tympanic plexus of nerves. Okay. On the medial wall, posterior to the so the medial wall is also known as the labyrinthine wall because it is related to the internal ear. ठीक है, और ये जो tympanic plexus है, it is going to give rise to sensory fibers to the mucous lining of the middle ear, the mastoid antrum, as well as the auditory tube, and it is given rise to this lesser petrosal nerve. Now, above and behind the promontory, is present the fenestra vestibuli. So out here, let's make the fenestra vestibuli. Okay, you have better place to label it, so you label it more clearly. My place is slightly less out here. In which is present the footplate of the stapes, fenestra vestibuli. Now, can you see the close relationship between this processus cochleariformis, which we gotten from the anterior wall, and the fenestra vestibuli? Now, this processus cochleariformis also marks the position of the geniculate ganglia, in case you want to know. Otherwise, you can forget it. There is no problem. Okay, so this is the footplate of the stapes would be present in the fenestra vestibuli. This way, the auditory ossicular vibrations are transmitted to the internal ear. तो ये basal turn of cochlea से बनता हुआ promontory है, cochlea. उसके बाद आया vestibule. So ये आ गया fenestra vestibuli. Now more posterior to it, on the medial wall itself, we're still talking about the medial wall, would be present a prominence which is formed by the lateral semicircular canal. तो अगर आप याद करो, internal ear के 3 parts थे. One was the cochlea, then was the vestibule wala part, जिस पर हमने fenestra vestibuli, and posteriorly is the semicircular canals. Now this lateral semicircular canal, obviously, because the lateral semicircular canal is going to form a prominence on the medial wall of the middle ear cavity, and this is the prominence which is formed right from the lateral semicircular canal. So let's label it lateral semicircular canal. Okay. Then more below the fenestra vestibuli is present the round window. This is the oval window, and this is the round window, or the which is in life, which has a secondary tympanic membrane which is placed on it, so that the vibrations of the internal ear are now of the perilymph is transmitted back towards the middle ear by the basis of this fenestra cochlea, which is present out here. Now, posterior to the fenestra vestibuli, in between the lateral semicircular canal and the fenestra vestibuli, is another prominence which is formed by the bony canal of the facial nerve. Now, ye facial nerve is lying in a canal, right? And this and forms a prominence, facial nerve, which forms a prominence on the medial wall. Now this is the labyrinthine wall. Now that gets us to the last wall, which is out here, the posterior wall. Now present in the posterior wall, number 1, is an opening, which is irregular in shape and is known as the adytus. I'm writing here, you can label it there. Adytus, which allows the middle ear cavity to communicate with the mastoid antrum and the mastoid air cells which are present here. So I'm going to erase all this and write here. You already have this part. So out here would be the mastoid antrum, which is the largest cell of the mastoid air cells. Opening in it are the other mastoid air cells, right? And this is the communication, which is the adytus in the posterior wall, through which the middle ear cavity communicates with the mastoid. Then the facial nerve forms a canal in the posterior wall, is related to the posterior wall and is exiting out here at the stylomastoid foramen. So it forms, then more is the vertical part of the facial nerve is present. The vertical part of the facial nerve forms a prominence in the posterior wall. Also present in the posterior wall is a pyramidal shape structure, which is the pyramid, to which attaches the muscle stapedius. And from here comes out its tendon, which goes and gets attached to the neck of the stapes. Right. And from the facial nerve arising and entering into the middle ear through this posterior canaliculus would be the cauda tympani nerve, which will run from here through the middle ear cavity and exit out through the anterior wall, where we have the anterior canaliculus. So in the posterior wall, the structures which are present are, number 1, the adytus. Then we have the pyramidal eminence, which is to which is attached the stapedius muscle, and then we have the canal of the vertical part of the facial nerve, which is exiting out at the stylomastoid foramen, which is present between the styloid process and the mastoid process. Below the adytus is a depression which is known as the sinus tympani, which is formed by the shut process of the incus. So this is a schematic diagram which tells you how the structures are related to the middle ear, what structures are impinging on its wall or forming impressions on its wall, and it is a very, 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 very important diagram. You should know this, how to draw this very well. This diagram is given in students' grays as well as it is given in Snell's, so you can use any one of these diagrams. So this picture out here shows us the posterior wall. This is the adytus, which is leading into the mastoid antrum. This would be the opening. This is the adytus leading into the mastoid antrum. Then there is this depression, which is the fossa incudus. Then the pyramidal prominence, in which is present the stapedius muscle, and it is supplied by a branch of the facial nerve, which is the nerve to stapedius. You can see how the muscle then becomes a tendon. The tendon goes and gets attached to the neck of the stapes. And this is the impression by matrix made by the facial nerve. The facial nerve enters through the internal acoustic meatus, makes an impression on the medial wall, and in the medial wall it is present between the fenestra vestibuli, which would be formed by this footplate of the stapes, and the prominence, which is formed by the lateral semicircular canal. Right? It runs through the medial wall and then comes on to the posterior wall. It's running in a bony canal and exits out through the stylomastoid foramen. Before exiting the middle ear, it's given rise to 2 branches within the middle ear. One is the cauda tympani, which passes through the middle ear, and one which is the nerve to stapedius. We will be doing the facial nerve in detail in a while. Now, infections of the middle ear are known as otitis media, and they usually take place secondary to respiratory infections. So, the respiratory infection or the infection travels via the eustachian tube to enter into the middle ear. So, the ascending infections of the respiratory tract enter into the middle ear cavity. Now, because of infection, the eustachian tube gets inflamed and the mucosa becomes edematous, and bulging of the mucosa narrows the eustachian tube opening. अब जब ये narrow हो गया तो अब whatever is the infection, it'll affect the mucous membrane of the middle ear, and it will result in formation of pus and edema of the mucous membrane out here. Now this is a closed cavity, and because eustachian tube bhi block ho gaya to aur bhi band hogi. Now it's a closed cavity completely. So the pus which has got accumulated now will find a way to exit somewhere. Either it starts bulging into the lateral wall. What was forming the lateral wall? The tympanic membrane. So bulging of the lateral walls is seen. The tympanic membrane becomes red. It is normally pearly white or reddish brown in color. Now it becomes red in color because it's inflamed. And sometimes if the amount of pus, the pressure increases so much, that it may even perforate. We talked about perforations of the tympanic membrane, which was either traumatic or due to secondary to infection. So now the perforation of the tympanic membrane can take place. The other opening which is present is the adductus of the mastoid antrum. So infections can now backtrack from the middle ear cavity through the addutus into the mastoid antrum. And that is what happened in the gentleman in our case, that the infection became so much कि अब वो mastoid antrum में चला गया और mastoiditis हो गया, which caused the enlargement or swelling which was seen behind the ear. And in certain cases, over chronically, when repeated infections, or in case it is a very virulent strain which is causing this infection, as a result of which the bony prominences, the bony canal, the facial canal can also get eroded. Repeated infections may cause the damage taking place to the ossicles may also get damaged, and as a result, conductive deafness may take place. And damage of the facial canal may result in symptoms of facial nerve palsy, as we saw. So the symptoms of otitis media include earache, bulging of the tympanic membrane. You can see how it's bulging out here. It changes. It's no longer the healthy looking tympanic membrane, and there is obstruction there is a blocked eustachian tube, which is adding to all these things which is adding to the problems. Now, perforation of the tympanic membrane can take place, and mastoiditis can take place because of the spread of infection through the addutus into the mastoid air cells. Now, let's look at the facial nerve. The facial nerve arises from the hindbrain and exits it at the pontomedullary junction. It again consists of two roots, a motor root and a sensory root, which is known as the nervus intermedius. Both these roots enter into the internal acoustic meatus along with the vestibulocochlear nerve and a labyrinthine artery, which is a branch of the anterior inferior cerebellar artery. While it is running in the it runs in the internal acoustic meatus over the internal ear, and on reaching the middle ear, it takes its first bend where there is a swelling, which is known as the geniculate ganglia. This geniculate ganglia contains the cell bodies of afferent fibers of taste. Thereafter, the nerve enters into the middle ear cavity. It is lying in the medial wall, in the bony canal, which is present in the medial wall between the lateral semicircular canal and the footplate of the stapes. That is where the fenestra vestibuli was. You saw it to be present anterior, inferior to the lateral semicircular canal, and superior to the posterior, superior to the fenestra vestibuli. From there, it forms a vertical segment when it is running in the posterior wall of the middle ear. While it's running in the posterior wall of the middle ear, it gives rise to a branch which is known as the nerve to stapedius, as well as it gives rise to the chorda tympani nerve. It thereafter exits through the stylomastoid foramen, The moment it exits through the stylomastoid foramen, it gives rise to the posterior auricular nerve, which will be supplying the occipital belly of the occipital frontalis. It will be supplying it will give rise to the nerve to posterior belly of digastric, and thereafter it enters into the parotid gland. On entry into the parotid gland, it divides into its two branches, which were the temporofacial and the cervicofacial trunks, from which arose the five branches which would ultimately supply the muscles of facial expression. Now let's draw a schematic diagram of the facial nerve so that we are able to understand Bell's palsy better. Now the facial nerve, as we just discussed, enters through the internal acoustic meatus. So let's draw the internal acoustic meatus. And entering into it is the facial nerve. The facial nerve, so please make a solid structure. The facial nerve enters and near the middle ear through the internal acoustic canal, and near the middle ear it forms a swelling which is known as the geniculate ganglia. Now the nerve has two roots. One is the motor root and this is the sensory root. Now from here, the sensory root fibers from here, in this ganglion, it gives rise to the first branch which arises from the geniculate ganglia, which is the greater petrosal nerve. The greater petrosal nerve is carrying the preganglionic parasympathetic fibers for the preganglionic parasympathetic fibers for the lacrimal gland, the nasal gland, and the palate glands on the palate. It is also carrying taste fibers from the palate. This joins the deep petrosal nerve and together they form the nerve to the pterygoid canal, which enters into the pterygoid canal and is relayed in the pterygopalatine ganglia, and we've already talked about it. You know the details about this particular nerve. Okay. Then some fibers of the nervus intermedius part continue with the facial nerve. Now this facial nerve enters into the medial. So this was the geniculate ganglia. Let's just mark the geniculate ganglia also. And a branch which arose from the geniculate ganglia, which is the greater petrosal nerve. This is the geniculate ganglia. The nerve, please make a solid structure. I'm telling you again and again, my structure is more because I'm making a larger diagram, so I'm not wasting my time on coloring it. Now it enters into the middle ear, and within the middle ear, it is first lying on the medial wall in between the lateral semicircular canal. It's running in a bony canal, okay? The canal for lateral semicircular canal, and this is the fenestra vestibuli. Then it goes on into a vertical part which is present in the posterior wall, gives rise to another branch which is nerve to stapedius, which innervates the muscle by the same link. Then it gives rise, the first some fibers of now the remaining fibers of the nervus intermedius leave it as the cauda tympani nerve. Cauda tympani nerve, which is carrying preganglionic parasympathetic fibers for the submandibular and the sublingual glands, as well as the taste fibers from the anterior two-thirds of the tongue. The remaining nerve, now which is basically consisting of its motor component, will give rise to the posterior auricular nerve. Then you have the stylomastoid nerve to posterior belly of digastric, and then we enter into the parotid gland, divides into two trunks, which ultimately give rise to branches to supply the various muscles of facial expression. Okay? So these were, as you already are aware of, the posterior auricular nerve, nerve to posterior belly or digastric, and these were muscles of facial expression. You can label them. You've already made this diagram before with me, so you can make a better diagram of the same thing. Now, why is this important? Because of its course, the facial nerve can be injured at various levels. Number one, it may be injured at the level of the internal acoustic foramen if there is a neuroma of the vestibulocochlear nerve or some surgery is taking place in the posterior cranial fossa. That is first site of the nerve where it can get injured. An injury to the nerve out here will result in loss of lacrimation. It will result in loss of a decrease in salivation. There will be loss of taste sensation in the anterior two-thirds of the tongue. There will be hyperacusis because the nerve stapedius has got injured. Then there would also be facial paralysis of muscles of facial expression. So everything below this would get injured. Now, if there is surgeries which are taking place in the middle ear, or as we saw in our case in the gentleman, when the infection of the middle ear, repeated infections of the middle ear, eroded this bony canal and affected the middle ear. तो अब जब इस जगह पर इंजरी होगी, तब आप ये समझ सकते हो कि lacrimation won't get affected, but rest of the things will get affected. So the patient will complain of hyperacusis, right? Because this nerve has got injured, then there will be loss of lacrimation, salivation. There will decrease salivation would be there. There is loss of taste from the anterior two-thirds, and there would be, as well as there would be paralysis of muscles of facial expression. So it is very important to understand the order in which these nerves are arising. What is the course of the facial nerve in order to understand the symptoms which we are seeing. Bell's palsy, as we have discussed earlier, is the idiopathic lower motor neuron lesion. I'm using this word now because you're now going into neuroanatomy. So you should start getting familiar with certain terminologies. Idiopathic lower motor neuron injury of the facial nerve, which can take place anywhere while it's lying in the ear cavity. Right, when there is an injury. Now, depending on, we can infer the site of injury of the facial nerve depending on what are the symptoms which the patient is giving us. If it is just the loss of muscles of facial expression, we know that the injury is somewhere to the facial nerve post the posterior belly of post the stylomastoid foramen. या तो parotid में है या stylomastoid foramen के पास है. अगर उसके पास taste sensation का भी loss है और hyperacusis भी है, then we know that the injury is somewhere in the middle ear. So we need to know the order in which these branches are coming in and what is the area of supply of the facial nerve in order to localize the lesion. How would you test for the facial nerve? You can test for the taste sensation as well as you can test for the muscles of the facial expression, which we did earlier. For example, we asked the patient to blow to hold air in the mouth, like when we were checking for buccinator, to close the eyes. So we know that these muscles are intact. So with this, it's a wrap. Head and neck lectures are finished, and we shall see you again in neuroanatomy.